Okay. Good afternoon, everyone. My name is Sybil Majokweni, and I am from the HIV Mental Health Research Unit from the University of Cape Town. And I just want to say thank you for being here today, and thank you to INSU for having me and to do this presentation. And I just want to say all the views that are presented here are not those of the University of Cape Town and not of any of the National Department of Health of South Africa and the Western Cape Health Province. Okay, so I'm going to give a brief snapshot of harm reduction in low middle income countries. Harm Reduction International, on their failure to fund a report in 2021, mentioned that since 2020, which is during the time of the COVID pandemic, harm reduction implementation slowed down in low middle income countries. And in Eastern Europe and Central Asia, it was found that they were doing much better than other regions. And one might ask themselves why this is, and we all know that the one leading cause is lack of funding for low middle income country programs, and this is a significant barrier for intervention implementation. Most high income countries spend about 20 times more than low middle income countries on intervention implementation. And this affects the international targets that are set for all countries because low middle income countries cannot reach their targets due to the lack of funding. Of course, I've mentioned lack of funding, but just to say a little bit more on the barriers to implementation, harm reduction interventions low prioritized in low middle income countries, and that is not on purpose. That is due to the fact that health systems are overburdened and there is a lack of resources. What we mean by this is that a lot of these countries have high disease burden, such as HIV and TB. And then secondly, the other barrier to implementation is the framing and stigma on harm reduction interventions. So most times, there's no political will to advocate for harm reduction funding or harm reduction intervention implementation, because in these countries, it is still illegal to use substances, and other people still do not understand that substance use is also a public health issue, and it is viewed as more of a criminal justice issue and something that needs to be dealt with by social development departments. In as much as I would like to speak on all low middle income countries, the purpose of this presentation is to focus on Africa and then just bring it down to South Africa, where we are currently doing a micro-costing method on a clinical trial. So just to paint a picture of harm reduction in Africa, Africa is a continent that has over 54, well, not over 54, 54 countries, and it has the youngest population in the world, plus minus 400 million people in this continent between the ages of 15 to 35. In sub-Saharan Africa, 42% of adolescents and young adults, which is between the ages of 14 to 23 years, are reported to be using substances. And in 2018, only 11 countries had at least one needle and syringe service, and this is out of 54 countries. And only 9 offered methadone opioid treatment, and again, this is out of 54 countries. But that is not all bad, because we also have Kenya, who are doing really well, and they've been reported as a regional leader in harm reduction in Africa. So now I just want to talk a little bit about what Kenya is doing right and what the rest of Africa can maybe learn from Kenya. So with all the barriers that I've mentioned, Kenya acknowledged that substance use is actually a threat to the country's social, economic, and political progress. So what Kenya acknowledged is that people use substances for various reasons, and that poverty, unemployment, and other social factors are the reason why people tend to use substances. And they also understand that people do not need to be punished by the law, but they also need to be assisted to use substances safely and responsibly. They also shifted their focus from a criminal justice approach and looked at substance use from a public health approach. And they didn't only just talk about substance use and harm reduction programs. They invested financially in harm reduction interventions and also established 7 medically assisted therapy clinics. So most of the time what would happen is conversations will be had, but then there'll be no financial backing and there'll be no follow-up. But what Kenya did, they invested financially and then they started to see results. Kenya also recognizes people who use and inject drugs as a key population, and they linked their interventions to HIV and AIDS programs. So a lot of funding that goes into these countries in Africa, because of the high rates of HIV, they are channeled towards HIV and ART programs. So once they saw that the funding is there, they tried to make sure that they integrate harm reduction interventions within the HIV and AIDS programs. Now, it would be awesome that other countries would learn from Kenya, because Kenya also learned from Mauritius. Now, I just want to quickly touch on economic evaluations in low middle income countries. And again, my focus is on Africa. So there is definitely limited use of economic evaluations and no formal link in decision-making progress and in decision-making process. So as my colleagues mentioned, that we do need evidence in order for policymakers and decision-makers to make their decisions. So for as long as there is no formal link of economic evaluations in decision-making, especially in low resource settings, then we will end up thinking or assuming that there is no budget to do certain things. But as we move on with this presentation, you will see how this helps. So the commonly used method in low-middle income countries is cost-effectiveness methods, which my colleague Sean mentioned that it compares costs and health outcomes of 2 interventions. But now this method does not include implementation costs, and this is what low resource settings really need. Because when you present our governments with an intervention that you have tested and you say it is effective, the first thing they ask you is, how much does it cost? Of course, cost effectiveness is an important method, but and it presents the benefit of interventions in terms of number of deaths that can be prevented, but it is important. But in low resource settings, government officials require more than that to make decisions. This is why this afternoon I present microcosting as a better fit, because it looks at specific costs of interventions down to every single resource that is used in an intervention, therefore making it easier for decision makers and policymakers to identify how much is being spent on certain elements of an intervention, and then they can decide what can be teased out of the intervention because of certain costs and what they can do without, but still be able to make the intervention work. So the microcosting approach is quite intense because it means you need to get down to the nitty-gritties and collect data. So it requires a lot of time and a lot of resources. But as with everything, there are pros and cons, but this, I think it should work. And the benefit is that at the end of it all, you develop what we call a budget impact tool. And this tool can be used by healthcare facilities and by governments to decide on their budget planning and to decide on which interventions or which parts of interventions they think still need to be funded and those that don't require a lot of money. It is also important when you do the microcosting to engage stakeholders, that is the policymakers and the decision makers from the beginning, because you want to present them with data that is useful and relevant to them. So what usually happens is, as researchers, we will go in, test an intervention, figure out how much it costs and if it is effective or not, and then in the end we approach policymakers and decision makers and say, this is the intervention that we tested, this is how much it costs, and maybe you can try it. But then to them, it is really not relevant because it does not only fall in their priorities list, but then they can't read it because the data that's being presented does not make sense to them. Yes, they can see that a certain number of deaths can be avoided, but then they want to know at what cost, how much do we still need to pay for this? And of course, microcosting provides detail, as I've mentioned, in that they will see where they will need to cut or reallocate to make the intervention work or affordable. So now I would like to tell the South African story. So South Africa has a population of 59.89 million people, and the prevalence of recent substance use, according to the study at the bottom there, is that people from 15 years have reported recent use, and it is above the, it is double than the global average, sorry. And the commonly used substances are alcohol, cannabis, mandrax, and methamphetamines. Alcohol use in South Africa is the highest in Africa, and South Africa is actually the third highest in alcohol use in the world. There are 5.8 million people on ART in South Africa, and this country runs the largest ART program in the world. $25 billion is spent on HIV programs by the government and other funders. South Africa has treatment centers, and these are mainly rehabilitation centers. And they are registered and managed by the Social Development Department. The Department of Social Development is mainly made up of social workers, and at times the interventions that are delivered by the social workers mean that they cannot prescribe medications, because this is something that can be done by people who are specialists in medicine. Some of the treatment centers are private centers, and because of the high cost, they cannot be accessed by people or the general public. Substance use is actually one of the health sectors, which is the National Department of Health's items that is on their policy agenda. However, they do not allocate budget for interventions, harm reduction interventions, due to low resources. And they have suggested that departments in the provinces need to integrate screening and brief interventions within the budgets that are already allocated to them. This is where Project Kanya comes in. This is the clinical trial that we are currently working on in South Africa, in Khayelitsha. It is a randomized controlled trial testing an intervention to improve ART adherence among people living with HIV and using substances in Khayelitsha. So just to paint a picture of Khayelitsha for you, it is a township in Cape Town. It is the second largest township in South Africa. It reports the highest HIV rate in the Western Cape province, which is one province out of the 9 provinces in South Africa. It has poor housing, overcrowded, high unemployment rates, and a lot of violence is reported out of this community. So in Khayelitsha, Project Kanya works in 2 different clinics. The Town 2 clinic, which is funded by the City of Cape Town local municipality, and the Michael Mapungwana clinic, which is funded by the Western Cape Province Department. This is an image that we got from the Mail and Guardian of what Khayelitsha looked like in July 2024 during the winter rains. South Africa, well, actually Cape Town experiences the highest rain in the winter season. And this year it was reported that the rain reported in July, it was actually compared to the last time the high rain that was reported this July, the last time we saw that amount of rain was in 1956. So it is quite difficult for the interventions when they're being tested in these communities because, one, people face these kinds of conditions, and when they have to go to the clinics to attend their intervention sessions, they are unable to because they can't leave their homes to go and access these interventions. And secondly, sometimes they will leave home without any rain, but while they are attending sessions at the clinics, it starts raining, then they start panicking because they know that by the time they get home, they might not have a home because the whole informal settlement will be drowned and flooded. So we are currently doing a microcosting on this clinical trial. So this is just the first component of the economic evaluation that we are currently doing for the Project Kanya trial. So we have been experiencing a couple of challenges in that there is limited unit cost data on resources, as we have mentioned, that we have to calculate down to every single resource that is used towards the intervention. This includes urine tests, it includes syringes that are used, needles, everything, and it's been difficult to get some of this unit cost data. from the South African databases. And we've also had to conduct qualitative interviews, and I think my colleague also mentioned that when they were doing their microcosting, they interviewed about 19 people. 19 people is quite a good number. We struggle to get 2 to 3 people because the facilities that we work in, they are quite overburdened, and people that are involved in these interventions that we work in, they also have a lot of patients that are lining up to see them. So they try by all means to sit down with us and do these interviews because they're necessary, because we would like to find out how many people they see in a day, what the flow in the clinic looks like, how much time they spend with each patient, how many patients do they refer for substance use, how many patients actually take up their referral. It is also quite a challenge because these interviews are conducted in the local languages, and because of our advisors and experts who do not speak the language, we often have to translate these interviews into English, and some of the data that's collected in these interviews is at times lost in translation. And with the case of Khayelitsha and Project Kanya, because we work in 2 different facilities, we have Town 2, which is managed by a local municipality, and Michael Mapongwana managed by the Western Cape Province. So these are 2 different clinics with 2 different funders and 2 different budgets. So it is important when we do microcosting to capture these differences so that we don't end up with an intervention presented to one group of policymakers, for instance, hand over to the city of Cape Town results from an intervention that was implemented at Michael Mapongwana, which is a Western Cape Province clinic and has more budget. So Town 2 Clinic also has a co-located outpatient substance use treatment facility, and Michael Mapongwana does not have one. Again, this is something that is important to capture because it influences how much resources are being used. So for instance, Town 2 Clinic, when we implement the intervention, they have a partner, which is the substance use treatment facility, but Michael Mapongwana does not have a substance use treatment facility, so they do everything by themselves. So these interventions are implemented in 2 different ways, and therefore the costs are completely different, even though it's the same intervention. So the microcosting approach is able to capture these differences, and it is then able to present to policymakers the differences, and then they understand what they can take away from the 2 different results that they get, and then decide what they want to tease out from this. So overcoming the challenges that I've just mentioned. So the plan is to create and update unit cost databases because there isn't a really strong health information systems in our country. And the other thing that is also key is continuing to train and mentor local health economics experts, which is what is currently being done through this trial with Cornell University and the University of Cape Town. It is also important that stakeholders are engaged early on, as I've mentioned, when conducting these economic evaluations, because you want to make sure that in the end you present them with relevant data that they can use in their decision making. And it is also important to embrace the differences that I've mentioned under different budgets, different funders, and different communities. It is not all doom and gloom in Cape Town, as you saw with the picture that has floods. And of course, the Department of Health is coming to the table, and the City of Cape Town is also coming to the table in making sure that we test these interventions, conduct these economic evaluations, and better inform them in terms of what we can do moving forward. So before I end, I'd like to thank the University of Cape Town, the University of Maryland, Cornell University, the Department of Health in South Africa, the Western Cape Department of Health, and the City of Cape Town. And I've also realized that INSTRU is going to be in Cape Town next year, so we look forward to seeing you, and please do come visit us and see what we are doing in South Africa. Thank you.